Okay, so I guess we'll get started. Thank you, everybody, for joining us for today's Research Bites. It's the second in our series, and I'm incredibly excited to introduce both Grace Nichol and Dr. Katie Clow, who was one of Grace's supervisors on her project. And I'm going to just give a few housekeeping details before I pass it over to Katie to introduce Grace. We have everybody on mute right now, and so what we'll do during the question and answer period is if you want to either send your messages to either Andrea or myself, then I will moderate the discussion similarly to what we did last week. If it appears that we're generating a whole lot of conversation, there's few enough this time round that we might actually be able to have a fulsome conversation without there being too many people speaking over top of each other. So if that is the case, we'll attempt to open it up, and if it seems to be a disaster, we'll close it down. So that said, Katie, it's all over to you.
Can you hear me?
Yes, yep. I can.
Awesome. I apologize now if there's dogs barking. I'm trying to keep them under control. But it's my pleasure to introduce Grace Nichol today for her presentation. I met Grace about a year and a half ago when she started working on the project she's going to present on, and gotten to know her a lot, and she's been such a great student in our lab. So the project sort of emerged out of many conversations that myself and Dr. Reese and Dr. Evanston had, who are co-researchers on this, about how vets have really adapted to this emerging issue of Lyme disease, and to get an understanding on the practices and knowledge needs out there currently. So Grace was recruited as a summer student, and then she stayed with our lab as a fourth-year thesis student, and then she's going on to complete her MSc in my lab in the fall because we've just been so impressed with her work. And she's also working on a separate research project looking at isolation and strain typing of Borrelia. And she just finished her undergrad in biomedical sciences and has a ton of research experience in other labs as well. And in addition to being a well-rounded student, she's a TA and also volunteers in the community. So she's been a great addition to our lab, and I'm excited to hear her presentation today.
Thank you, Katie.
Go ahead, Grace.
Thanks, Katie, for the introduction, and thank you, Andrea and Jasmine, as well, for hosting this session today. As Katie mentioned, I will be sharing the results of a survey that was distributed to Canadian veterinarians about canine Lyme disease. Next slide, please. So first, I'll start with some background information. The black-legged tick, or Ixodes scapularis, is a vector for the bacterium Borrelia burgdorferi. This bacterium is the causative agent of Lyme disease, which can affect dogs, humans, and horses. And due to the harmful nature of this bacterium, it's a concern for canine health. So some common clinical signs of canine Lyme disease include shifting lameness, fever, and anorexia. And in rare cases, it has been documented that a potentially fatal protein-losing nephropathy or Lyme nephritis can occur. However, the majority of dogs that are seropositive for the bacterium don't develop clinical signs. Next slide, please. So over the past decade, the range of the black-legged tick and canine seropositivity of Borrelia burgdorferi have increased in Canada. In addition, there remains a lack of consensus regarding best practices for diagnosing and treating canine Lyme disease. So examples of this limited consensus, as noted in the American College of Veterinary Internal Medicine, or ACVIM, consensus statement, include canine vaccination against Borrelia burgdorferi and the appropriate treatment for dogs that are seropositive but not exhibiting clinical signs. Therefore, the objective of this study is to determine the current methods and strategies used by Canadian veterinarians to identify and treat canine Lyme disease, and we did this through the use of a survey. Next slide, please. The survey received REB approval, or Research Ethics Board approval, at the University of Guelph, and was then formatted using Qualtrics software. The survey was distributed to Canadian veterinary medical associations and industry groups, the National Association, and the Saskatchewan, Manitoba, and Newfoundland and Labrador associations confirmed that the survey was distributed to the veterinarians in their contact list, and the Ontario Animal Health Network responded that the survey was passed along for review. And although a response wasn't received from the other associations, the survey may still have been distributed to their networks. So after the responses were collected, the data was reviewed and cleaned to ensure that only responses from Canadian veterinarians were included. And the collected data was analyzed using descriptive statistics, spatial analysis, and logistic regression. Next slide, please. So now I will introduce some of the results of our survey, beginning with information about the respondent population. In total, there were 192 survey responses, and the first pie chart on the left shows that the type of practitioners that answered the survey were small animal practitioners, mixed animal, and other. So the majority of respondents were small animal practitioners, comprising about 90%, and about 9% were mixed animal practitioners, and the 1% in the other category were either researchers, professors, or clinic owners. The second chart concerns the length of time that respondents had been in veterinary practice. About half of the respondents had been practicing for 15 or more years, and about a quarter of respondents had been practicing for less than 5 years. Next slide, please. This graph shows that we received responses from veterinarians in every province. About half of the respondents were from Ontario, seen by the tallest bar near the middle of the graph, and the next most represented provinces were Manitoba and Nova Scotia, and the least represented provinces were New Brunswick and Quebec, with 4 respondents each, which is shown by the bars near the Ontario bar in the middle. Next slide, please. So next, I will be describing the topic of clinical experience, and I'll be presenting some of the spatial analysis results, which was done using QGIS software. Respondents were asked about the frequency of tick sightings on dogs in their area for each of the 4 seasons, and they were asked to rate the frequency of the tick sightings. Sorry? Oh, sorry, I thought I heard someone on the line. They were asked to rate the frequency of tick sightings on a scale, and their options were all of the time, regularly, occasionally, and rarely. And this legend is seen at the bottom of the slide. Responses were also mapped for respondents who did not answer the question, which would be the blue dot. The responses were mapped using the centroid of the respondent's provided forward location address, or FSA, and some points were adjusted slightly if the FSA centroid was located in water or if responses directly overlapped. So these maps show that all of Canada, and there's a total of 186 points on each map, and there's a high level of green and blue dots seen for the winter chart at the bottom right, and compared to other seasons, meaning that respondents rarely saw ticks or did not answer the question for this season. And in the western provinces, we see a lot of red and orange, indicating reporting seeing ticks all the time or regularly in the spring and in the summer. And in the eastern provinces, we see lots of red and orange in the spring and fall, with some also seen in the summer. And when looking at Ontario especially, it can be hard to see all of the points. So the next slide will show a zoomed-in view of Ontario and Quebec. Next slide, please. So on each of these maps, there's 96 points. We see that tick sightings are high in the spring, and there's a similar pattern to the maritime provinces, with more orange and red seen in the fall than in the summer. And again, in the winter, we see the trend of many green and blue dots, indicating rarely seen ticks or not answering. Next slide, please. So now I'll be introducing some of the logistic regression models that were made using our software. Logistic regression was used to examine the potential provincial differences, and response categories were grouped to make the results binary, and a significance level of 0.05 was used. In this slide and in the upcoming slides, only results that were significant will be shown. Ontario was used as the reference for all of these questions due to it being the province with the highest number of respondents. So the first question, which is shown on this slide, was analyzed related to the reported establishment of black-legged ticks in respondents' practice areas. So we see about 62% of respondents reported that black-legged ticks were established in their practice area, and about 38% responded that black-legged ticks were either sporadically introduced, non-existent, or unknown. And it was found that the odds of a respondent reporting that black-legged ticks are established in their area is higher in Ontario compared to Alberta, British Columbia, and Newfoundland and Labrador, and it's higher in Nova Scotia compared to Ontario. Next slide, please. Next, respondents were asked about the annual prevalence of dogs in their practice that are seropositive for exposure to Borrelia burgdorferi. So we see about 36% of respondents reported that less than 1% of dogs were seropositive, and 64% reported that greater than 1% or an unknown percentage of dogs were seropositive. So the logistic regression revealed that the odds of a respondent reporting that the annual prevalence of dogs in their practice area that are seropositive for Borrelia burgdorferi is less than 1% is greater in Ontario compared to both Manitoba and Nova Scotia, and it's higher in British Columbia and Newfoundland and Labrador compared to Ontario. Next slide, please. The next question asked about the change in the annual prevalence of dogs that are seropositive for Borrelia burgdorferi over the past 5 years. So 64% of respondents said that the prevalence had increased, and about 36% of respondents reported that the prevalence had either decreased, stayed the same, or is unknown. And the odds of a respondent reporting that the seropositivity prevalence had increased in their area is higher in Ontario compared to Alberta, British Columbia, Newfoundland and Labrador, and Saskatchewan. Next slide, please. So now I'll be sharing the results from the scenario questions. Oops, sorry. My slides are in the wrong order for me. Sorry, I meant clinical approaches. Respondents were asked about what they will do after removing a tick, and the results are shown in the pie chart on the left. So about half of respondents reported that they would identify the tick in-house, so the orange sector of the pie chart, and about 29% reported that they would send the tick to a laboratory for further identification, and 21% reported that they would not proceed with any further examination of the tick. So from the 50% that answered that they would identify the tick in-house, they were directed to a question asking about their tick identification skill level, which is the top bar graph shown on the slide. And the majority of respondents, around 77%, reported that they think that their tick identification skill level is average, which on the survey was defined as being able to differentiate American dog ticks from black-legged ticks. And about 18% identified their skill level as expert and 5% as beginner. So from the first graph, the 21% that said that they would not proceed with any further examination of the tick were directed to a question about their reasons for not further examining the tick. And for this question, respondents were able to choose more than one response. And the top 4 responses were that they felt that neither themselves nor their staff have sufficient training for tick identification, the factor of financial cost, that they find it a challenge to find time for tick identification, and that they do not believe there is clinical value in tick identification. Next slide, please. The first chart on the left displays pathogen testing frequency. So 19% of respondents reported always testing black-legged ticks for pathogens. 44% reported sometimes testing, and 37% reported never testing the ticks. For the bar graph on the right, you see that respondents were asked when they recommend the Lyme vaccination, and they were also able to select more than one response for this question. About 57% of respondents noted that they offer the vaccine as a non-core vaccination based on the lifestyle of the dog, and only about 4% of respondents reported that it was recommended as part of their clinic's core vaccinations, and 17% of respondents noted that they never recommend the Lyme vaccination. Next slide, please. So this is my scenarios section. So I'll be sharing results about questions that were posed to respondents about scenarios that they might encounter in practice. So respondents were encouraged to outline their action plan for the 4 scenarios presented. And since the veterinarians were able to write out multiple steps for each question, the sum of the responses that are shown in the upcoming bar graph do not add up to the total number of responses for each question. And only the top 5 responses will be shown, and each question had at least 5 steps that were outlined by 18% or more of respondents. And the responses are arranged in the order that was most commonly reported to be carried out in practice, not in the order of most popular answer to least. And it's important to note that some steps may be performed in a different order or done concurrently in practice. So scenario 1 was a dog presents to the clinic with an attached and engorged black-legged tick. And the most common steps included removing and testing the tick, discussing both canine Lyme disease and tick prevention with the owner while monitoring for clinical signs. And also we saw scheduling a future 4DX test for 3 weeks later or more. Scenario 2 is a dog presents to the clinic for its annual exam and tests seropositive for exposure to Borrelia burgdorferi. The owner has not seen any clinical signs of Lyme disease. And here we again see a discussion with the owner taking place, both about canine Lyme disease and tick prevention. We also saw the top answer for this question was to perform a urinalysis, which would be used to check for proteinuria. And other top responses included administering a quant C6 test and antibiotics. Next slide, please. The third scenario was a dog presents to the clinic with a 2-week history of shifting lameness. Here we see the most common response is to administer a 4DX test. And again, we see the mention of administration of antibiotics. And respondents also reported that they would conduct a physical exam, administer a CBC and biochemistry panel, and perform radiographs to check for other causes of lameness. Next slide, please. Scenario 4 was a dog presents to the clinic with polyuria, polydipsia, lethargy, and vomiting. Biochemistry reveals elevated urea and creatinine, and testing was positive for exposure to Borrelia burgdorferi. The most common response was to administer antibiotics, and most respondents said that they would administer doxycycline. As well, the top responses included hospitalization and administration of IV fluids, performing urinalysis, administering a quant C6 test, and testing for renal disease or failure. Next slide, please. So this last section, I'll be talking about resources. And for these questions, respondents were able to select more than one response, and only the top 3 responses will be shown on the slides. The respondents reported that they would find it helpful to have more information on treatment best practices, diagnostic best practices, as well as current Lyme disease risk. And veterinarians reported finding most of their information on canine Lyme disease from the Veterinary Information Network, conferences, and the ACVIM consensus statements. Next slide, please. We were also interested in respondents' reported comfort level in diagnosing and treating canine Lyme disease. So this chart shows that just over 50% of respondents reported that they were somewhat comfortable diagnosing and treating canine Lyme disease, with about 27% of respondents reporting that they are very comfortable, and about 17% reporting that they are uncomfortable treating canine Lyme disease. And in the future, this will be contrasted to the provinces to see if there are any geographical differences in responses. Next slide, please. So the survey responses illustrate a lack of consensus consistent with what was seen in some parts of the ACVIM update on Lyme borreliosis. For example, in the ACVIM update, there was no reported consensus regarding Lyme vaccination, which was also seen in the survey responses. As well, the survey results show that there is not one standard approach to clinical decisions regarding pathogen testing and tick identification, and there were differences in reported levels of comfort when diagnosing and treating canine Lyme disease. So when looking at the results from the scenario questions, it was seen that the percentage of respondents who selected similar steps was often below 50%. As well, the scenario descriptions became more suggestive of canine Lyme disease, and we saw with this more variability in responses, seen by smaller overall numbers of respondents selecting any of the top 5 responses. As well, there were some geographical differences in when tick sightings peaked across Canada, seen by the mapping questions, with spring and summer being the peak seasons in Western Canada and spring and fall being the peak seasons in Central and Eastern Canada. And this aligns with tick phenology and current research, since germ center species, which are commonly seen in Western Canada, are prevalent in the spring and the summer, and the Ixodes scapularis seen in provinces like Ontario are most active during spring and fall. It appears that there's also geographical trends in responses, as well as in tick distribution and Borrelia burgdorferi seropositivity, which may have led to the differences in clinical experience and approaches. Next slide, please. So it's important to consider some of the limitations of the study. We had a relatively small sample size of 192 Canadian veterinarians, which led to challenges with finding significant logistic regression results. For example, some provinces, notably Prince Edward Island, New Brunswick, and Quebec, did not have any significant differences from Ontario. And this may be due to the small sample size and number of responses from these provinces, rather than not truly differing from Ontario. And some questions require that response categories be combined in order to analyze the data, which was seen with logistic regression. As well, sometimes not all questions were answered, which was seen with the inconsistent number of responses across the seasons for spatial analysis questions, and inferring the cause of this can't be done definitively. There's also the possibility that selection bias may have been present, since the recruitment strategy may have targeted veterinarians who are actively online. Next slide, please. So now that we're aware of some of the methods and strategies that are currently used by the veterinarians, we are able to focus the development of educational tools to topics where there's the greatest need. We can also develop documents containing some of the agreed upon best practices concerning canine Lyme disease. And since we have feedback regarding where veterinarians get their information from, we can ensure that the documents are available through these sources. Next slide, please. So I'd like to acknowledge the other researchers working on this project, Dr. Michelle Leveson of the Atlantic Veterinary College at VPEI, as well as Dr. Scott Weiss and Katie Clow of the Ontario Veterinary College. And I would also like to acknowledge the funding provided for this project by the Undergraduate Research Assistantship Program of the University of Guelph and the Andrea Ledger Dunbar Summer Research Assistantship from the OVC. And that brings me to the end of my presentation. Thank you all for listening, and I think Jasmine's opening it up now for questions and possibly a discussion.
Thank you very much, Grace. That was great. We do have a few questions here, and we have a little bit of time. So firstly, your results seem to mimic what we have found in medical professionals as well, with their comfort level in identifying tick species and identifying Lyme disease, which is an incredibly difficult disease to actually diagnose if you don't see some of the very obvious symptoms, such as the bull's eye. What is your recommendation in order to ensure that medical practitioners have a better grasp on how to do this in a timely fashion?
For that, I'm going to refer people to the ACVIM statement, as I'm not a vet, so I don't want to provide any medical advice there, but I would say that to identify it without symptoms, there would need to be a 4DX test or some kind of seropositivity test. And with that, there's also the question of not diagnosing dogs that don't have clinical signs. So if the Lyme disease isn't present, there's still research being done to see if there should even be a treatment if there is no clinical signs. I hope that answered the question.
For sure. It's a difficult environment, right? So totally understand you falling on internal medicine group. So with regards to your statistics, as I'm sure you're aware, there are going to be big differences when you're comparing to large provinces that have multiple respondents versus those provinces where you have very few. How did you adjust your odds ratio in order to ensure that your results were reliable?
Yeah, so we used logistic regression, and we used that binary categorization to try to combine some of the response categories so that we could get larger numbers that would hopefully be more valuable. Like for the question on seropositivity prevalence, we had to combine categories that were greater than 1%. In the survey, we initially had like 1 to 5%, and then 5 to 10%, and so on. But we found that since the numbers were so small in those categories, it was better to combine the results and get a stronger logistic regression model. And that's why also we used Ontario as the reference to hopefully use the power that comes from having those larger numbers rather than using a reference from a province that was not as well represented in the survey.
Okay, and if you were to continue with your survey, and so right now you have 192, if you were to send it back out and increase your survey numbers, how would you change your overall statistical analysis?
Yeah, with that, I would hope to, with more responses, open it up to do more like multinomial regression, where we can combine all of those response categories to more provinces and also get stronger power on those provinces that were less represented. And with multinomial regression, I could also change up the referent more, so I could combine, for example, the Western provinces to each other rather than having everything be compared back to Ontario.
Great. And then with respect to actual treatment protocols, did the participants have the opportunity to explain their rationalization for their antimicrobial use prior to any diagnostic testing?
Yes, so for the scenario questions, they were able to, it was an open-ended response, so they could write out their approaches, and a lot of them did have sort of like if statements in their responses. For example, for the last scenario with all of those symptoms, that would be classical for canine Lyme disease. A lot of them said, well, if I get a result on this test, then I would do so-and-so step. So it was difficult to accommodate for those in the charts. So yes, there's definitely more information provided about antimicrobial use and so on from the results, and in the manuscript there will be more explanation of those, the use of those.
Great. And so one last question. Was there any kind of comparison with respect to how respondents, how they responded based on geography and which tick species would actually have been present in each part of the country?
Yeah, so for those questions, especially I think that ties into both the mapping and the logistic regression questions. Some questions weren't specific to Ixodes scapularis ticks, they were asked about just ticks in general. So some of those were considered for the mapping results for the spring and summer versus spring and fall, because, for example, in the Western provinces, we do see like the dermacenter Andersoni and being present in like, BC and Alberta, and those being more active in the spring and fall. And then Ixodes scapularis and being more present in the spring and fall, and then dermacenter was the spring and summer. So those considerations were thought about with the analysis, and that will be further extended upon to the tick phenology in the final report.
Okay, great. Unfortunately, we're out of time because this is just a small bite of your research. So we look forward to reading your manuscript. And thank you so much for taking the time to present to us. And thank you to everyone for joining us today. Next week, we actually will be having Dr. Yana Schur join us from Rwanda to talk to us about snake envenomation. So May is going to be an exciting month. So thank you very much, everybody, and have a great day. Stay safe. Remember to wash your hands. Bye.
Thank you, everyone.